I am Dr. Captain D.K. Ramawat, consultant non-invasive cardiologist working at Ramawat Heart and General Hospital, Badmer. Today we are taking one topic, interventional. In this we will discuss the appropriate tools in calcified lesions and complex percutaneous coronary intervention with its tips and tricks, because this coronary intervention is going on throughout the global and in every country monthly, and they are discussing very deeply, and that too physically, not by webinar. So it is very important, and cardiologists are very keen to learn it. And so let us come and discuss the calcified lesion intervention. So this is appropriate tools in calcified lesions, complex percutaneous coronary interventions with tips and tricks. This is important because we are discussing tips and tricks. So let us take first introduction. What is the definition? Complex coronary intervention can be defined as interventions which have lower success rate, high acute complications, and poorer long-term outcomes. First percutaneous balloon angioplasty was done by Grunty-Zig in 1977, and then in 1986 Paul and Sigwart deployed the first coronary stent as a scaffold, means making a platform to prevent vessel closure during PCI and reducing the incidence of restenosis. In 2002, there was the introduction of drug-eluting stent, which reduced rates of restenosis and need for a repeat revascularization, that too less than 10%. Now we want to know that what the complex coronary intervention include. Number one, left main disease. Second, multivessel interventions. Third, intervention with severe artery calcification. And fourth, chronic total occlusion intervention. Then we want to know the complex and higher risk indicated patient include what? They are patient specific or lesion specific or hemodynamic specific with comorbidities. So first we take the patient specific. They are advanced age, renal failure, diabetes, and impaired LVF. Then lesion specific, unprotected left main stem. Second, CTO, chronic total occlusion. Then third, heavy calcified artery. Then saphenous venous graft intervention, and then bifurcation lesion, and lastly critical 3-vessel disease. Now hemodynamically specific we will discuss, means comorbidities. So here you will see the cardiogenic shock, acute coronary syndrome, unstable arrhythmias. How to define unstable arrhythmias? If the mean arterial pressure decreased by 15 mm of mercury or more, they are called unstable arrhythmias. Now, due to complexity of managing these high-risk cases, a heart team approach is advocated. Better patient selection and management and subsequent care, we need heart team approach. To treat patients safely and effectively, the operator should possess the necessary skills set to perform complex revascularization as a basic prerequisite, means preparation. Now we will take the left main intervention. So here we would like to know what are the high risk persons. So in high risk persons, you see, we will divide it into three points. Either it is anatomical or hemodynamically or comorbidities. So anatomically, high risk is number 1, left main stenosis. Second, last remaining patent vessel, because this is actually it is a complex high risk coronary anatomy, so it is also included in high risk. Then we take the hemodynamically risk. Here you see acute coronary syndrome, reduced ejection fraction, that is less than 35, and unstable angina. Then if we go to comorbidities, then COPD, advanced age, paralytic, and CKD, and heart valve diseases. And now you can see here below it current guidelines to left main disease, European Society of Cardiology guideline and American College of Cardiology and American Heart Association guidelines regarding doing the PCI and CABG difference you can see. So we will go to left main intervention. Unprotected left main stem disease is considered if it is more than 50% stenosis observed. In 5 to 7% of patients undergoing coronary angiography, this remains a major therapeutic challenge to cardiologists. Remember, this remains a major therapeutic challenge to cardiologists. So here, medical treatment is associated with a 3-year mortality rate of 50%. Then second, coronary artery bypass grafting, CABG, regarded as the gold standard treatment in this group, has here significant mortality benefit in comparison to medical therapy alone. Then thirdly, with introduction of drug-eluting stent and adjunctive pharmacotherapy, PCI is equally safe and effective in unprotected left main stem in some studies. Drug-eluting stent implantations have shown results comparable with CABG in terms of MACE. MACE are adverse cardiac events. CABG still remains the procedure of choice for treatment of patient with high risk anatomy. So we are dealing left main. So here the current European Society of Cardiology and American College of Cardiology and American Heart Association guidelines consider PCI for ULMS disease, unprotected left main stem, a treatment option only in absence of complex left main stem anatomy. And to summarize the data of randomized controlled trial, unprotected left main stem PCI, there are 3 points only. Number 1, in left main, if we take the syntax trial between PCI and cardiac surgery, there was no significant major adverse event up to 5 years. Second, PCI had a lower stroke, 2% versus 4%, but higher revascularization, means 27% versus 16% compared with CABG patients. Thirdly, the PCI with drug-eluting stent was non-inferior to CABG with respect to the rate of composite endpoint of death, stroke, MI at 3 years. At 3-year composite of death from any cause, stroke and MI occurred in 15.4% of patients in the PCI group and 14.7% in CABG group. So now we will go to intravenous ultrasonography. What is the utility? The finding of this study suggests CABG might be better than the PCI for treatment of unprotected left main stem coronary artery disease. So let us start now the utility of intravenous ultrasound sonography. We can see here, it can characterize the plaque distribution, composition and lesion severity. Then we can from it we can judge mechanism of luminal enlargement. We can judge precise quantitative measurement. We can judge guidance of directional atherectomy. We can judge optimal stent deployment. We can judge characteristic of plaque for intervention. Now here you can see this figure. Here intravascular ultrasound guided treatment of severely calcified lesion. Now the third point is procedural planning. In procedural planning, careful assessment of severity of coronary artery calcification and lumen compromise, whether true or false, we have to see. Second, estimation of the risk of procedure should be seen. Third, the selection of an appropriate debulking strategy should be noted. Then to guide revascularization appropriately, we use FFR, fraction flow reserve. FFR is a quantitative measurement of functional severity of coronary artery stenosis. It is calculated by dividing the pressure distal to the blockage by pressure proximal to the blockage. So equation will be FFR is equal to PD divided by PA, means PD means the mean pressure distal to stenosis and PA is the mean aortic pressure to measure pressure proximal to blockage. FFR is measured during cardiac catheterization. A normal FFR is 1 and an FFR lower than this, means 0.75 or 0.8, is generally considered to be associated with myocardial ischemia. FFR is measured by computed tomography. Now we have to see the lesion closure factors. What are the factors which can close the lesion? Unstable angina, thrombus, ostial lesion, tandem lesion with severe stenosis, lesion calcification, chronic occlusion, multi lesions and multivessel CAD, then angulation more than 45 to 60 degrees, then long lesion more than 20 mm, then the branch point stenosis, then the no spleen given before the angioplasty, then suboptimal activated clotting time, then balloon to artery ratio should be is the point, because it can close the vessel. It should be more than 1. If it is more than 1, residual stenosis is more than 30%, and dissection long or spiral. Now let us go to risk of fatal outcome. When it can be fatal? If ejection fraction is less than 35%, age more than 65 years, 3 vessel or left main CADs they are, recent MI less than of 24 hours and no prior CABG, Jeopardy score if it is 2.5, Jeopardy is estimating the amount of myocardium at risk and female gender. Then we see the Jeopardy scoring system. 1 point give where? For each myocardial lesion supplied by the target lesion, give 1 point. Another 1 point is given for each myocardial lesion supplied by a vessel with diameter stenosis 70%. Then give 0.5 point for each myocardial lesion that is hypokinetic at baseline and not supplied by a vessel with significant stenosis. Then we have to do potential candidates for supported angioplasty. who requires the supports. Number one, target lesion supplies the majority of viable myocardium. If GFR score is more than 3, if there is cardiogenic shock or multivessel disease, then we go for risk factors: aortic valve disease, left main PTCA, shock, acute MI less than 24 hours, type C lesion, multivessel diseases, unstable angina. Now we see pre-procedural consideration. Here we will see risk class, risk factor and complications. So if risk class is low, risk factors will be 0 and complication will be 1.3%. If it is risk class is moderate, then risk factor is 1 to 2 and complication 2.6%. If risk class is high, then risk factor is 3 and complications is 8.6%. If the risk class is very high, then risk factors are more than 3 and complications will be 23%. Now, what is the treatment of calcified lesion? You have to note here one thing: direct stenting should be avoided. Direct stenting should be avoided. The lesion or plaque has to be modified to receive the stent. Intravenous imaging, very important. Intravenous imaging, particularly OCT, optical coherence tomography, provided valuable additional information on the thickness, depth area and arc of coronary artery calcification and lumen area. When it is feasible to deliver an imaging catheter, IV imaging based calcium score may be used to plan the debulking strategy. If the calcium score is low, less than 2 or 2, a non-intravascular lithotripsy, balloon based treatment may be selected. If the score is high, intravenous lithotripsy or step up debulking with rotational atherectomy till optimum calcium thickness is less than 0.5 mm is achieved. And here is the figure which will show you the algorithm for crossing chronic total occlusion. Here again there is a figure. You will see here optical coherence tomography guided bioresorbable fold implantation in a severely calcified. Here actually we prepare a machan, means a platform. From there we deal with that calcification. And this is the main figure which we have to know and which it should be on our tips, because it's a very important figure. It's a decisional algorithm for the treatment of calcified coronary lesions. You say, if the angiography has been done and it shows you mild calcification or moderate to severe calcification, then what to do? And first of all, you must know, by doing intravenous ultrasound and optical coherence tomography, what is the calcium arc. If it is 180 to 280, 2 points should be given. If it is more than 270, 3 points should be given. If it is more than 5 mm of the length, then 2 points are given. And if thickness of calcium is more than 0.5 mm, 1 point is given. So we go now for mild calcification. Here you will do balloon pre-dilatation. So in pre-dilatation, first you do stent implantation and optimization with intravenous ultrasound and OCT. And secondly, suboptimal balloon expansion if occurs, then go to lithotripsy directly, and then stent optimization should be done. And if you see in this calcification, if it is you see if 1 to 2 points or 3 to 5 points, if you get 1 to 5 points in calcification, then high or very high pressure non-compliant balloons are used. We will go further to discuss the type of the balloons. Then suboptimal results if you C, then directly go to lithotripsy. If you get 3 to 5 points of the calcification, then directly lithotripsy should be done. If it does not cross, then directly you do rotational atherectomy or this your orbital atherectomy. And if they both are suppose suboptimal balloon expansion, go for lithotripsy. And if optimal balloon expansion is seen, go for stent optimization. Now here we will discuss a little bit about balloons. First is non-cutting, non-compliant balloons. It is high pressure balloon. Balloon needs to expand to a specific diameter and exert high pressure to open a blockage. Then compliant balloons. In this, balloons will keep expanding as the pressure increases and does not have a specific range. Then cutting balloon, third. It has a special balloon tip with small blades that are activated when the balloon is inflated. The fourth is scoring balloon with double lumen. Here it is semi-compliant balloon with 3 triangle shaped scoring element attached proximally and distally on the outer surface of the balloon with double lumen. Here again this is the figure which shows you algorithm for use of rotational or orbital atherectomy management. Now we have come to the second figure, which is also most important as the one we have discussed earlier. Here we will see the debulking devices. What are those? So if you see moderate to severe angiographic calcification, then intravenous imaging should be done if it is feasible. If it is feasible and you have seen nodular calcium, then go for this orbital or rotational atherectomy and then balloon dilatation. And if it does not optimize, then then you can do the rotational atherectomy and calcium optimum lesion preparation should be done and stenting done, and stenting guided stent optimization is done. If you see that this IV intravenous imaging is not feasible, then directly go to rotational atherectomy, confirm optimal lesion preparation and do imaging guided stent implantation. Now we will go to debulking devices. First we take the cutting balloon device. Fixed arm cutting balloon dilatation device, a proven tool for the mechanical challenges of complex lesions that are often resistant to conventional balloon. What are those? In-stent restenosis and then resistant lesion, small lesions, small vessels, bifurcations, aorta ostial lesions and saphenous vein graft lesion, and before stenting. Here you will use the cutting balloon. ISR is in-stent restenosis when a coronary artery that has treated with a stent becomes re-narrowed by a blockage. Then what are the tips and tricks? This is the main important thing. That is why we are discussing it. So this was actually cutting balloon device. So here in cutting balloon device, what are the tips and tricks? Number 1, 6 French or bigger guiding catheter used with optimum backup support. Then secondly, support guide were necessary. Third, a balloon artery ratio should not exceed 1.1:1. Shorter length for tortuous vessel used. Negative wet preparation of the cutting balloon outside the body and with sheath is advised. Slow inflation and deflation means 1 atmospheric air pressure every 5 seconds should be given, required. Angiography before each inflation is done. Avoid torquing means force insertion because catheter between inflammation because it may result damage to vessels. Now second we go to scoring balloon device. Here scoring balloon with the power to safely dilate resistant lesions. Scoring balloon catheter is indicated for treatment of hemodynamically significant coronary artery stenosis, including instant restenosis. What are the complications in it? Number one, coronary spasm, coronary dissection 10%, perforation occurs with balloon oversizing, late aneurysm can occur, device entrapment defined as the inability to remove equipment from the body with manipulation. Now, third we have come to intravascular lithotripsy device, very important. Intravascular lithotripsy is a technique that uses acoustic shock waves to break calcium deposit in the coronary and peripheral arterial vasculature and major aortic arc and in distal abdominal aorta and in iliofemoral vasculature. Now advantages of intravascular lithotripsy over all other calcium modifying devices. Remember, advantage of intravascular lithotripsy over other all calcium modifying devices. First, it is a short learning curve. It has got short learning curve. Then it can be delivered over a regular workhorse wire, steel guide wire designed to provide support, torque and lubricity to pressure through the various complex anatomies. Then plate modifications does not rely on wire bias to reduce the side wall tension. Does not cause no reflow phenomenon, useful in acute coronary syndrome. Side branch can be protected with wire during lithotripsy. Now what are the tips and tricks? We have come only to learn tips and tricks for intravascular lithotripsy device. Number one, use backup guides and supportive wires to improve deliverability. Use resorbable with a small burr rotating blade in balloon undeliverable lesion prior to intravenous lithotripsy. Size the balloon should be 1:1 to the preference vessel. Use negative preparation to avoid bubbles. Be aware of ventricular captures. You can see in this figure ECG that capture beats are there and fusion beats are there because this occurs in the VT. So you have to be aware of it. Be aware of R on T phenomenon leading to ventricular tachycardia, ventricular fibrillation, atrial fibrillation and torsades D point is when blood flow through the right coronary arteries is severely compromised, then it occurs and I have shown it in the figure. Now inflate the balloon to 6 atmosphere rise pressure after each cycle to assess the response and the need for additional cycles. Now we are taking rotational atherectomy device, a medical procedure that uses a diamond tipped burr to remove plaque from coronary arteries. Indicated in what? Calcified lesion, fibrotic lesions, lesions that can't be dilated with a balloon catheter or stent. It's also useful when lesions are so called stenotic that a stent can't be delivered to its target. Rotational atherectomy is generally used to abrade, scrap superficial calcification with a single bar rotating blade to improve lesions compliance before treating the lesion with balloon dilatation and stent implantation. Now what are the tips and tricks? We have come here to discuss tips and tricks only. So what are the tips and tricks in rotational atherectomy device? First, hold beta blockers 24 hours prior to the procedure. Adequately hydrate the patient pre-procedure. Then temporary pacing should be done in right coronary and dominant left circumflex lesions. Here you have to note one thing. Right coronary artery supplies the blood to the right side of the heart. The SA node branch of the right coronary artery provides blood to the SA node. The atrioventricular nodal artery delivers blood to the AV node, and the marginal branch of the right coronary artery provides blood supply to the lateral portion of the right ventricle. So hence, temporary pacing is necessary here. The next left circumflex coronary artery. This is the dominant artery supplies small branches that perfuse the atrioventricular node. If perfusion to the atrioventricular node is decreased, it can lead to dysfunction. So, temporary pacing is necessary. Guide catheters with simple curves and coaxial alignment to reduce the bias should be used, because tortuous and angulated vessels, a stiff stainless steel guidance may increase the risk of dissection and perforation. Avoid spring type Y connectors, because it creates an electrical contact between two components, because it limits modification of individual requirement. Wire the lesion directly with rotawire using a torque rotational force. Wire the lesion directly with rotawire using a torque rotational force device. Check draw DRAW. D means check dip from catheter sheath tip and beneath advisor, and R means rotational. Set the RPM at 1,80,000 RPM. And A means here advancer. Check the movement of advanced knob. And W, wire. Check wire clip is attached and tug on the wire while rotating to ensure the brake is activated. Now we are discussing this. Continue. Avoid activated bulb advancement within the guiding catheter. Beware of wire looping at the guide catheter tip. Platform the burr in a disease-free zone proximal to lesion. Ensure free flow of contrast beyond the burr. Relieve any forward tension on the drive shaft and guide wire. Ablate the lesion with gentle packing motion and move forward only when there is slight light resistance. Do not allow RPM to drop more than 5,000 from the platform speed. Limit runs to less than 20 seconds. Give enough time for the artery to perfuse in between ablation runs. Watch for number 1 slow flow, ECG changes and hypotension, and always keep with you atropine, vasopressor and dilators on the table. Never advance the burr to the point of contact with the spring tip, a radiopaque point which is 0.014 inches. Do not keep the rotating burr in the same position for a long time. Always withdraw the burr to the platform segment before stopping it. Finish with a polishing run. No RPM drop, no resistance. Now we have come to the major complications of rotational atherectomy. So here complications are divided into 3 portions. Number 1 is slow flow or no reflow. Second, perforation. Third, burr entrapment. If there is slow flow or no reflow, the causes are large bursts and higher speeds and shorter time interval between ablation runs. And in perforation, the oversized burr is there and angulated lesion is there. And in burr entrapment, burr crossing the lesion without adequate ablation. Excessive tension on the burr jumps forward when activated. Now managing, how we manage these complications regarding slow flow and no flow, retraction of burr, optimization of perfusion pressure. Intracoronary vasodilators should be kept at hand like nitrates, adenosine, verapamil and nicorandil. Then intra-aortic balloon pump support should be there. Then for perforation you use reversal of the anticoagulation. For example, you are using warfarin, then vitamin K and 4-factor PCC is used. If you use heparin and low molecular weight heparin, then potassium sulfate should be with you. And if you use the dabigatran, apixaban, betrixaban, edoxaban and rivaroxaban, then you must have the anti-axanate alpha and 4-factor prothrombin complex concentration should be there. And also prolonged low pressure should be used. Prolonged low pressure balloon dilatation should be done, and covered stent implantation should be done. And covered stent means made up of metal stent covered with fabric or graft material such as PTEF, polyethylene, polytetrafluoroethylene, and surgical closure and distal grafting should be done. And in case of birth trapment, gentle controlled traction should be given with guide catheter, deep intubation, or mother and child catheter, or balloon inflammation besides the birth should be given, and snare assisted traction should be done, and surgical removal can be done. You must know here actually what is mother and child catheter. It is a stiffer directional catheter for controlled engagement of left vein in patients with difficult anatomy, especially distal ascending aorta. Now lastly we take, not lastly, but fifth point we are dealing orbital atherectomy. It removes plaque from artery wall and prepare non-calcified leaf plaque for stent implantation. The orbital motion allows the continuous flow of blood, saline, and particular debris distally that reduce potential ischemia. It lessens the incidence of slow flow, no reflow, and device success less than 50% residual stenosis, and before stenting, and procedure success less than 20% residual stenosis after stenting. The in-hospital 30 days and 6-month MACE was noted, and it was non-QAMA 6% and 8% respectively. 33% of patients followed over 5 years. The 2, 3 and 5 years MACE rate 15.2, 18.2 and 21.2 respectively. Stent delivery was successful in 97.7% cases. Angiographic complication occurred in 2.3%, perforation 0.7%, dissection 0.9%, and no reflow 0.7%, and emergency CVG in 0.2%. Now the rotational atherectomy versus orbital. Orbital atherectomy has multiple advantages: low incidence of no reflow, decreased crown entrapment, and less thermal injury, improved stent expansion, the lower incidence of stent strut malapposition, means lack of contact between the stent and arterial valve. Now lastly, this is I think lesser atherectomy. Use the laser to remove plaque from the arteries and remove blood flow. Leonardo, high energy laser, a gas laser which facilitated coronary angioplasty on hard and complex calcified balloon resistant coronary lesions. There were no major procedure related complications. Periprocedural MI, transient slow flow, and ST elevation occurred in 7.1, 3.6 and 3.6% of patients respectively. Patient developed MACE at 6-month follow-up on target lesion revascularization and 1 death and MI. Now multi-vessel percutaneous coronary intervention we are supposed to know. So here you will see it involves intervening in at least 2 epicardial coronary vessels on their or their branches during a single procedure. It is used to treat patients with STEMI and multivessel disease. Multivessel PCI can improve outcome for these patients. It reduces the risk of all-cause death and cardiac death. It may reduce the risk of reinfarction. It may reduce the need for repeat revascularization. Complete revascularization in all comparing CVG with PCI have reported similar mortality rate with 2 treatment technique. So here you will see PCI is preferred with multivessel coronary artery disease. 3-vessel disease should in general not to be treated immediately but discussed by heart team. Percutaneous coronary intervention with 2nd generation drug-eluting stent resulted in similar rate of mortality. Means mortality 5.7 versus 11.4 and MI 0%, 4.3%. Repeat revascularization 4.3% versus 8.6%, and angina 10% versus 18.6%. PCI with 2nd generation drug-eluting stent was not inferior to CABG in terms of motility, MI, and repeat revascularization and angina. Multi-vessel coronary intervention in high-risk patient, suppose we do, then you just see the syntax trial has shown CABG is the standard of care. CABG is the standard of care for patient with complex lesion. And if it is high or intermediate score, then in patient with less complex, low syntax score or left main coronary disease, PCI acts as an acceptable alternative. Now CABG is a class 1 recommendation in multi-vessel disease with high complex lesion. Patient with hemodynamic impairment like impaired LV function, hemodynamic instability and underlying comorbidities, a recent MI, CHF, diabetes, COPD, CKD, valvular heart diseases and increased age have increased the perioperative risk and denied surgery. Now, a heart team approach should be undertaken and patients who are at very high surgical risk or inoperable for surgery should be considered for high risk PCI. There is no universal definition for high risk PCI. It is determined by degree of complexity of the coronary artery disease and clinical comorbidities. A high risk procedure which are prolonged in duration and have increased risk of no reflow or slow reflow, intra-aortic balloon pump should be used. In high risk PCI, mainly in cardiogenic shock defined as protected PCI, various mechanical support devices are used. For example, axial flow pumps, impella, left atrial to femoral artery bypass pump like tandem heart and extracorporeal membrane oxygenation. Use of these devices prevent hemodynamic instability which can result from repeat episodes of reversible myocardial ischemia that occur during planned temporary coronary occlusion and may reduce peri and post-procedural adverse events. Now, this is the last figure. It is not the end of the teaching, but it is the last figure I made. Here you will see technical skills and training requirement for the care and revascularization of patient with high risk and severe coronary artery disease. So what are the complications? Number 1, CTO, coronary total occlusion. Second, left main stenosis and bifurcation. Third, calcified disease. Fourth, multivessel disease. Fifth is poor hemodynamic status and ventricular dysfunction with coexisting complex artery anatomy. And sixth is stent under expansion restenosis. And seventh, complication management. So, if there is CTO, then dual access and injections are used, like antegrade and retrograde techniques are used, especially wires, microcatheters, devices for increasing guide support, and externalization techniques should be used. And in left main stenosis and bifurcation, single and two stent strategies, both primary and provisional bailout use should be done, and intravascular images should be used, and rotational or orbital atherectomy should be used, and intravascular imaging should be done. And in multiple vessel disease, coronary physiology studies, fractional flow reserve should be found out, and intravascular imaging should be done. And in poor hemodynamic status, you should do left and right ventricular percutaneously implanted support device should be used. Then intra-aortic balloon counter pulsations should be used. Then extracorporeal membrane oxygenation can be used, and large vessel access and closure management and transradial expertise. When both femoral arteries are used, then that is used transradial. And alternative access consideration like axillary and transcaval. You might, of course, transcaval is also there. So transcaval means involves using femoral vein access and then using a surgical radiofrequency cutter to bore hole from the inferior vena cava into the aorta to allow a TAVR, transcatheter aortic valve replacement delivery catheter, to pass through, and an alternative access auxiliary transcaval. Now stent under expansion or restenosis, you use intravascular imaging, aggressive, non-compliant and plaque modification balloons or high-speed balloons. Atherectomy, lesser or rotational should be used. Ventricular brachytherapy is used. So, this brachytherapy actually it causes no regrowth in the coronary arteries. It is very useful. And in the complication management, you see echocardiography should be done for pericardiocentesis, and covered stent like coils and beads should be used, and snares and steering technique can be used, and dual guide technique can be used, and dissection or re-entry to salvage distilled flow can be used, and endovascular rescue is also used, that is the pacemaker and ICDS. Now this is the last slide. Last but not the least, current status of atherectomy device. Atherectomy devices continue to have an important role in modern PCI era, and more so with the aging patients population and increasing procedure complexity. Judicious use in those who derive maximum benefit is most important. Now the conclusion: calcified coronary lesions are often complex and pose challenges to interventional cardiologists. Calcified coronary lesions are often complex and pose challenges to interventional cardiologists. Careful patient selection and procedure planning are essential. Intervenous imaging guidance and appropriate use of atherectomy devices are the cornerstone of procedure success and good long-term outcome. Complexity of case is defined by constellation features including anatomical characteristic, hemodynamic instability, underlying comorbidities like making them high risk or inoperable for CABG. The need of hour is what? The need of hour is adequate training of interventional cardiologists. The need of hour is adequate training of interventional cardiologists to deal with this high risk PCI cases rather than shying away or referring them for CABG only or considering them as a doomed or inoperable. Thank you.